You can crush a 10K race, feel unstoppable, have zero warning signs, and still be growing a widowmaker blockage inside your chest. How does that make any sense? Because your body doesn't reward fitness with a safety guarantee, it rewards survival with adaptation. And it's so good at adapting that it can keep blood moving even when a major artery is in trouble, right up until the instant it can't. That's why a frightening number of people don't get a clean, dramatic warning. Sometimes the first hint of heart disease isn't pain, it's the event. So today, I'm going to show you why a heart that looks healthy can still fail, how your body hides these problems in plain sight, and the most practical way to check your heart before you're relying on luck. To understand why a strong engine can still stall, we have to look at what the heart actually needs to keep running: oxygen. The heart is a muscle with an enormous oxygen appetite. It works non-stop, and it can't take a break. To feed that demand, it depends on a set of vessels wrapped around it, your coronary arteries. The name comes from crown, because they look like one, but here's the better mental picture. Think of them as the root system of a giant tree. If one major root gets cut, the part of the tree it supports doesn't struggle for long, it starts dying fast. There are two main roots in this story: the right coronary artery and the left coronary artery. The left quickly gives rise to a huge branch called the left anterior descending artery, LAD. In emergency rooms, the LAD has a nickname that's as blunt as it is brutal: the widowmaker, and it earns that name because of simple geometry. The LAD supplies blood to a massive chunk of the left ventricle, the heart's main pumping chamber. Block a small twig, you lose a leaf. Block the trunk, the whole tree goes down. Most people wonder the same thing. How does a blockage form in someone who runs, eats pretty clean, and feels fine? It starts at the artery wall. A healthy artery is springy and flexible, like a brand new garden hose. The innermost lining, the tunica intima, is meant to be smooth, almost like a non-stick coating, so blood cells glide by without friction. But life isn't a lab experiment. Over years and decades, things like high blood pressure, high blood sugar, and smoking can rough up that lining like sandpaper. And even the sheer mechanical pounding of high-volume blood flow year after year can contribute to tiny microscopic wear. You won't feel these micro-injuries. They're too small to trigger symptoms. But your body notices, and your body tries to patch them. It sends LDL cholesterol, often called the bad cholesterol, to the site like filler used to seal a crack. Then immune cells show up to check the repair. They ingest the cholesterol, swell into foam cells, and over time the repair site hardens. That hardened mix, cholesterol, calcium, and cellular debris, is plaque. The process is atherosclerosis. Now, this is the belief that blindsides people. Most of us picture plaque like a clog in a bathroom drain. The opening narrows and narrows, and we assume we'll feel it happening. More shortness of breath, more chest pressure as the space for blood shrinks. That story feels logical. Biology often takes a different route. As plaque builds, the artery can actually expand outward, preserving the opening where blood flows. It's like the wall of the hose bulges slightly to keep the inner channel usable. This is called positive remodeling, and it's one of the reasons people can carry a large amount of plaque and still have normal blood flow with zero symptoms. So, if the artery can hide a huge problem, what turns it into a disaster? It comes down to stability. Picture plaque not as a rock, but as a blister, soft, inflamed, packed with messy inflammatory material, and covered by a thin cap. If you hit a sudden surge in blood pressure or extreme exertion, that fragile cap can tear. That's a plaque rupture. And when it ruptures, the contents spill into the bloodstream. Your body reacts exactly the way it's designed to react. It assumes there's a serious injury and rushes in platelets to form a clot. That's perfect when you cut your finger. Inside a coronary artery, though, that clot can be fatal. Because the clot can build quickly, minutes, and seal the artery shut, the real killer isn't always the slow, gradual buildup. The catastrophe is the sudden clot that plugs the vessel like a cork jammed into a wine bottle. Blood flow slams to a stop, heart tissue downstream starts dying. That's a type 1 myocardial infarction. But there's another scenario that can hit endurance athletes and hard chargers, because the artery doesn't have to be 100% blocked for the heart muscle to get injured. Meet Robert, a 50-year-old dedicated runner with normal cholesterol who trains consistently. During a race, he doesn't grab his chest like a movie character. He just suddenly feels wrong. His energy drops, he gets lightheaded and nauseated. He tells himself it's dehydration and tries to push through. At the hospital, doctors find troponin in his blood. The easiest way to think about troponin is like the liquid inside a glow stick. As long as the plastic casing is intact, the liquid stays inside. Crack the casing and the liquid leaks out. Heart muscle cells are loaded with troponin. If those cells are injured or die, troponin spills into the bloodstream. That's why troponin is such a big deal. So Robert is having a heart attack. The surprising part? His arteries aren't completely shut. The scan shows only moderate narrowing, around 50%. So how do you have a heart attack if blood is still moving? Because this isn't always a pipe-closed problem. Sometimes it's a supply and demand problem. On the couch, a 50% narrowing can be a non-issue. The hose is kinked, but there's still enough water to keep the grass alive. But when Robert's heart rate rockets to 170 beats per minute, his heart suddenly needs a fire hose worth of blood. A partially narrowed artery can only deliver a garden hose worth. Demand outruns supply, and the heart muscle starts suffocating. That mismatch is ischemia. In Robert's case, add one more ingredient and the situation gets even worse. Atrial fibrillation, AFib. Your heart runs on an electrical timing system that creates a coordinated squeeze. In AFib, the top chambers don't pump cleanly, they quiver. The timing gets sloppy. If you combine a partial narrowing with a racing heart and chaotic rhythm, you've got a perfect storm. The heart is working harder, filling less effectively, and receiving less oxygen right when it needs more. This also connects to the 70% idea people hear about. Many people don't feel classic chest pain until narrowing becomes more severe, often when an artery is significantly obstructed. Below that, the body can compensate. Above that, you may notice exertional tightness that eases with rest. Clinicians often call that stable angina, basically your body's check engine light. This is what changes the whole story. A lot of heart attacks happen in people with less than dramatic narrowing because softer plaques are more likely to rupture than big, stable, heavily calcified ones. The small plaque can be the dangerous one if it's unstable. So, if symptoms aren't reliable, are you just rolling the dice? Not entirely. Your heart has a backup plan: collateral circulation. Think of your main coronary arteries as interstates. If traffic is jammed for years, the body can start building side streets, tiny alternate vessels that route blood around trouble spots. That's one reason an older person might survive an event that could be fatal for someone younger. The older heart may have had time to build detours. In a younger person, a sudden rupture can shut down the highway with no way around it. And this is where training matters in a deeper way than most people realize. Steady aerobic work, zone 2, plus properly dosed intervals like HIIT, high-intensity interval training, can encourage vascular adaptation and help expand that network. Because when things go wrong, the only thing that truly buys you options is time. In emergency medicine, there's a saying: time is muscle. The longer the heart goes without oxygen, the more permanent the damage becomes. Around 20 minutes, irreversible injury can begin. Around 90 minutes, more tissue can turn into scar. Scar tissue doesn't pump, which is why recognizing symptoms matters, and why symptoms aren't one size fits all. Some men get the classic Hollywood pattern: chest pressure, pain radiating down an arm. Many don't. And women are more likely to have subtler signs: crushing fatigue, shortness of breath, nausea, back or jaw discomfort, or what feels like intense reflux. And if you ever get a sudden, overwhelming sense that something is seriously wrong, cold sweat, collapse in energy, a wave of doom, don't brush it off. Get help. If the plumbing fails, cardiologists can often restore flow with PCI, a procedure that opens the artery, often with a balloon and a stent. A catheter is threaded in, often through the wrist. Contrast dye maps the blockage, a balloon opens the narrowed area, and a stent acts like a metal scaffold to keep it open. But prevention is the real goal, finding the fire before the house is burning. Here's the problem with normal labs. Standard blood work can tell you what's circulating in your blood, the ingredients, but it can't tell you whether those ingredients have been sticking to the artery walls for years. If you want to see what's actually happening inside the plumbing, you need imaging. A coronary artery calcium scan, CAC, is a fast scan that looks for hardened, calcified plaque. A score of 0 is generally reassuring. A very high score, like over 400, can be a serious red flag. But calcium scans mainly catch plaque once it's hardened. They can miss softer, earlier, unstable plaque, the blister kind that hasn't calcified yet. That's where a CT coronary angiogram can come in for certain people, because it can visualize the artery and reveal plaque patterns that basic tests might not show. It's not for everyone, but for the right person, it can function as a powerful early warning system. And that's the big takeaway. A healthy heart attack is often a tragedy of missing information, not a moral failure, not laziness, just not having the data that would have changed the plan. So control what you can control. Keep blood pressure in range to reduce mechanical stress on artery walls. Manage blood sugar to reduce inflammatory damage. Keep moving to build long-term resilience. And if you're in a higher risk group, don't rely on how good you feel or how fast you run as proof that you're safe. Use the tools we have, with a clinician who takes prevention seriously. Because the goal isn't just to be fit. The goal is to still be here, years from now, with a heart that can keep up with your life. Well, if this made you think differently about your heart, share it with someone you care about, and I'll see you in the next video.